everyone's time, and we have a fantastic session planned for you this afternoon. So first of all, I want to welcome all of our expert presenters. I want to welcome Adam and Dena and John. In a moment, I'll hand over to them to introduce themselves. But before we do, we are thrilled that you guys are here this afternoon. For folks who may not have joined one of our Playbook Masterclass sessions before, this is an instructional series running through the fall to really sort of work with you and discuss with you core elements of the playbook, to really take a deep dive into different aspects that we cover in the comprehensive sort of how-to guide, and sort of really engage in discussion around some of those best practices that we recommend, give a few examples that perhaps we didn't illuminate in the playbook, and give you some sort of real-time tales from the trenches from some of our experts working on this important topic. So today, this is probably one of the most important topics for our emerging field of digital medicine as we move these technologies forward. How can we make sure that we are ensuring equity and justice as we deploy these technologies? I'm going to hand over to my colleagues in a second, but before we do, I'm just going to run through a couple of housekeeping things about how all of you on the line can be engaged in our session today. So just a quick note, we will always disclose, we are recording the session today. So the session will be available for playback later in case you want to share it with your colleagues. Today's slides will also be available. You'll be able to find everything at playbook.dimesociety.org starting this afternoon. The other piece is when it comes time to Q&A, there's a couple of ways you can engage. During the live Q&A section, you can raise your hand, I'll try and call on you, and you can ask your question directly to the experts. You can also use the Q&A function that you'll find in the ribbon throughout the course of the presentation from our experts. And I will moderate those questions when we get to our discussion period. So with that, that's enough of me. Let's dive in on this really important topic for discussion. I'm really delighted to welcome Adam Brown, Dena Mendelsohn, and John Wilbanks. And with that, I'll hand over to you.
Great, thanks, Jen. I'm going to speak extremely briefly because I really want to get to go over to what Adam's going to be sharing with us. I thought I would explain first the idea behind the equity and justice in remote monitoring section of the playbook. And the idea here was to make sure that when individuals or groups are planning for using connected technologies in the clinic or in trials, that they work proactively to incorporate ethics by design into the planning at the forefront in order to reap the benefits and avoid pitfalls. We think that this section will help teams in better understand what those potential pitfalls are, and we also include suggestions for ways to minimize or avoid those pitfalls altogether. The last thing that I wanted to note is that there are many ethical considerations when we're talking about healthcare, both in the United States and outside. And so we are very aware that there's so many of them, and we could not touch on all of them in the playbook. And so what we are clarifying is that in the playbook, when we talk about ethical considerations, we're talking about ethical consideration in particular when it involves connected sensor technologies. So there are also additional ethical considerations involved in healthcare today. Those should also be part of proactive planning, but it's not covered at the same extent as what's involved in connected sensor technologies. So with that, I'm so excited to introduce Adam Brown and hear from him today.
Hello, everyone. So my name is Adam Brown. I am the CEO of ClinArc. Our focus at ClinArc is to increase clinical trial awareness and access with a focus in underserved communities. But yeah, so I'm happy to be here. I'm really excited to share my perspective with you all and insight. So let's get after it. So one thing that I want to start with is explaining the difference between equity and equality, because I think sometimes those lines get blurred. Equality is when everyone has the same thing. Everyone can get a pencil, right? Equity is when everyone can get those things, but the people who need it most have the resources necessary to get it. So I like to think of it as, education. You send everyone to college, but not everybody is ready for college. So we have to make sure that there are, resources in place so that everyone is brought up to speed and everyone can perform. So that's how you should view equity. In terms of justice and fairness, that's going to be making sure that the entire process has the proper oversight, and making sure that it's all fair, making sure that that everything is maintained and people are able to get those resources, but not at a some crazy advantage. So I want to also stress the importance of diversity, which is not on this slide, but diversity in our teams is going to be how you really is. Sorry, did someone send something? I saw something below. Sorry, but diversity on our teams is going to be very important, especially when we're talking about building ethics into the culture of the team, because you need those perspectives. You need to have people from different backgrounds. You need to have people that have experienced different things throughout life, because you're gonna have blind spots naturally if you're only looking at it from one perspective. So that's why education is important, and really instilling a culture of ethics. You have to be intentional with your decision making when you're designing these projects. Next slide, please. So trust. Trust is very important. So trust in technology is the bedrock of broad adoption. There are legitimate reasons to not trust digital monitoring technologies, from weak legal protection to bad actors and regrettable oversights. We have to make sure that the people that are going to be using the technology trust it. This is very, very, very important. I can't stress it enough, because if they don't trust it, you're going to have a hard time. So all of us working to advance the use of remote monitoring must ensure fairness and equity in how technology is deployed. We must avoid or minimize the harms that may be introduced to the people that are going to be using this technology. And we must also make sure that they have the education that's important to really make sure that they're able to use that technology. As researchers, we have to make this our top priority, because if it's not going to work. Simple as that. It's going to be challenging. Next slide. Now, this is where the challenge comes, the engagement piece. So the reason trust is important, I'll give you an example. I remember right before my wedding, right? I had to send out invites, of course, me being the guy that I am. I was the last person to get the invites out. My wife was yelling at me, she was mad. And I'm thinking to myself, oh boy, let me text everybody I know, hurry and get these invites out. So of course I have to text my grandma, right? So I text my grandma, hey, please send me your address. I'm terrible with remembering addresses, by the way. So I text her, didn't hear from my grandma for a week. So I'm on my end freaking out because I can't get an invite to my grandmother. I finally, get to talk to her, and she says, well, I don't like sending my address over the phone. I don't know who's watching. And I'm thinking to myself, being the millennial that I am, grandma, there are 7 billion people on earth. Nobody is worried about you. I'm sorry. That's just not the case. But we have to be mindful that there are people out there that do not trust technology, and they will not engage with it if they do not trust it. So we have to make sure, as we're planning our trials, our research, that when we use this technology, the people must trust it. It is very important. Next slide, please. So comfort with sharing personal data, whether health information, biometrics, device collected data, or online activity, was the lowest among older consumers, and those that are less educated. The issue with that is, these are the individuals that actually need the technology. This is why I actually created my company, because, you know, we need to increase access. We need to get people involved in trials. We're seeing this with COVID. We're seeing this with, you know, we're seeing this in clinical research as a whole. You know, we're leaving people out. And we have to find ways to bring them up to speed. We have to make sure that there's transparency in the way that we communicate, you know, this information to them through education, all of that. You know, they have to understand that we are looking out for you. This is not about us. This is not about us trying to know stuff about you that we shouldn't know. You know, we are truly trying to help. So educating them on, you know, on how, you know, on the technology is going to be crucial in really kind of bridging that gap. Next slide, please. Promoting a culture of ethics. When remote monitoring is deployed, there are a number of questions that the ethical team must consider beyond simply putting digital measurement products in the hands of patients or participants. This is basically saying, when you start your trial, don't just say, oh, we need, you know, we need wearables and just giving it to people, because not everyone knows how to use them. Not everybody, you know, is going to say, hey, you know, I feel comfortable with, you know, wearing this. You know, we have to make sure that when we deploy this stuff, it's fair and it's equitable. We have to address these things as well. We have to identify where the issues are going to be, and we have to address them. Some of the questions that, you know, you know, these questions can be divided into, you know, two broad categories. So what issues must be addressed so that participation is fair and equitable, and what patient safety issues may be created by the technology, and how can they be minimized? So we have to think about this, you know, as we're developing, you know, our trials, because like I said, if we don't, it's going to be challenging. And back to the whole diversity thing. If we instill diversity into our teams, and we make sure that our teams are diverse, this is going to naturally, we still have to pay attention to it, but it's going to happen. There are going to be people on your team that are going to say, hey, we might want to think about this, you know? So we have to, you know, bring it back to the whole diversity thing as well. We need to make sure that there are, you know, diverse minds at the table, so to speak. Next slide, please. Now, questions at the heart of fairness and equity when deploying remote monitoring. So some of these questions that we need to be thinking of is going to be, you know, what about tech literacy? You know, you know, using my grandma's example, she's probably going to hate me if she sees this. You know, I literally watched my grandmother go to the grocery store, and, you know, I could just see her get mentally overwhelmed when she saw the little scanner with the little, you know, she had to slide her card in and they had to press the numbers. It was overwhelming for her. So we have to be mindful of that. We have to understand that, you know, especially if we're going to underserved communities, people may not even be used to this type of technology. You know, we have to understand that it's just, for some people, it's not normal to see this stuff, you know? You know, so we have to also understand, you know, or ask questions like, you know, who has access to the technology? Does the tech require more tech? Does the tech compel participation? Let's see, you know, will technology skew the trial? So an example of, you know, it skewing the trial could be, you know, I deploy this technology into the trial, and, you know, come to find out, you know, this individual has no idea how to use the app, you know. So you're gonna have people that have no idea how to use it, and some people that do. That's going to create some issues. So we have, like I said, we have to make sure that everyone is brought up to speed. We have to make sure that they are engaged in a way that they feel comfortable, that they, you know, are truly able to digest the information. You know, for me, one thing that I've seen in terms of clinical trials, a lot of people, you know, where I'm from, they feel comfortable hearing information from me, or from someone that looks like them, because you're able to really connect. You're able to really, you feel like you're talking to someone that shares your experience, and that's very important. That is very, very important as we begin to, you know, roll out remote monitoring into our trials. Next slide, please. Failure to identify and address issues of fairness and equity can limit access and skew samples. So this is essentially what I was touching on before. It is critical to address issues of fairness and equity when deploying connected sensor technologies in order to ensure that all patients and participants in clinical trials have equal access and opportunities to voluntarily participate. Now, you'll understand the equal access part, once we get to the other slides, but essentially, if we're not checking all of our boxes, we can actually do more harm than good, in a sense that we may deploy it and people can't even access it. People can't, they don't even have the resources at home to make sure that they can use the technology. So we have to make sure that is taken care of as well. So this may even be, before we start the trial, really asking people like, hey, understanding what kind of situation they're in, understanding what their needs are, before you run the trial, because you don't want to start the trial and then find out that, half the people don't have internet at home. That's going to be a bad situation. Next slide, please. Who has access to the tech that powers remote monitoring? I'm not going to read all, sorry. I saw a question. Can I answer that?
Absolutely.
How can teams access diverse patients and get feedback before deploying a trial? So great question. So in these situations, I'm a big fan of surveying, of really understanding, engaging the people before you start the trial. I think individuals should be engaged, the community should be engaged throughout the entire, as we're planning, they should be involved. They should, we should be getting that feedback. Because that also, kind of softens the blow in terms of, you encountering challenges down the road. You're going to want to know, is this age group? Because depending on the patient population that you deal with, you may be dealing with a different age group. It just varies. So you may want to know, like, will these individuals like wearing this device? Do you have access to this at home, or can your insurance afford it? All these types of things are going to matter. So we have to assess this up front. We have to, like I said, we have to reach out to the community. It's that simple, and really ask them, hey, this is what we're doing. That goes back to the transparency part, just flat out asking them, hey, this is what we're working on. We want to help the community. We want to get your feedback so that when we do this, we want to make sure that it has you in mind. And I think that will go a long way, because once you actually start running that trial, they're going to already know what's happening. They're going to know, they're going to feel comfortable. It's not going to be something new. It's not going to be you just randomly coming up with, whatever the device is. It's not going to be new to them, because you've already been engaging them. They've been involved in the process, all that good stuff. So it's going to be important to do that when before you deploy your trial. I hope that answers your question. Next slide, please. Now, this goes back to this slide really speaks on, the whole access to like internet, access to resources. So if you are deploying, say you want to deploy an app for your trial that maybe you want to track visits or sleep, whatever it is, if they don't have internet, that's going to be an issue. Another real life story. My great grandmother. She so I called I like to check up on her, and of course I'm the bad grandson because I'm always working. So I call her. She's like, I'm still alive, and so I was talking to her one day, and I said, how's everything going? What are you up to? And she said, oh, I'm fine. I had to get rid of that Wi-Fi. And me, I'm thinking, how? Like, how can you live in the 2000s and not have Wi-Fi? But she was perfectly comfortable with it. She reads the newspaper. She doesn't need Wi-Fi. She still orders the newspaper comes to the door. She doesn't, she has a flip phone with the little baby screen, not even the big screen. It has, like, so there are people out here that will genuinely be left out based on the decisions that we make. And how we determine the devices and technologies that we deploy for the trials. So we have to be mindful of that. That's why it goes back to surveying and asking people, because you don't know. If you're looking at something like, I'm just throwing an example out there, prostate cancer. It's going to be an older individual. You don't know if those individuals are going to be using Facebook, smartphones. You don't know what they're going to be using. So you have to really assess. You have to really assess what what they feel comfortable with up front, or else you're going to run into issues where, maybe they don't have access to computers, smartphones, tablets, all those things. Like I said before, real world example, I've seen it. I've experienced it. I come from the same communities where these resources are limited. I went to a high school that had no textbooks. Everything was worksheets. So we have to be mindful of all these things as we're interacting with these communities, because it really is a situation where it's not a one shoe fits all. It's all, we have to be very precise with the technologies that we pick, because it's just going to be very critical, and it can affect the outcomes as well. Next slide, please. Now, limited broadband reach. This is essentially talking about, how it's what I was touching on before, how, internet and how people not everyone has access to internet. Connected health technology only works when it can connect. For many in the United States and around the globe, access to reliable internet connection is not a given, and we have to keep this in mind. Not everyone can afford it. Not everyone, not everyone even knows how to use it or set it up. And I think that as one of the scary things about running clinical trials is that you don't know what's going to happen in recruitment. You're not sure about really anything. Everything's a guess until it happens. So that's why I'm very I'm all for reaching out to the community, and just simply asking them. We have to be transparent. We have to get them to understand that we're there to help, because that is above all, that is very, very, very important. Being forward thinking about who may be left out, when clinical trials in healthcare go digital, like I said, is going to be very important. Exploring strategies to include those populations. We have to do that. I've run into numerous situations where I'll give you another. Just from my work and my career, I spend a lot of time working as an analyst, where my job was around creating the strategies for clinical trials and really getting sponsors, CROs, everyone to understand where the patients are going to be. But a lot of the times, we avoid the tough locations, which is why you see predominantly individuals that are white in clinical trials and not those that are from diverse groups. We avoid places like, Africa, because it's just hard to get to the patients. And having this type of technology is it's so important, because it gives people access that literally would not even know about the trial. They wouldn't even be able to get, not necessarily know about it, but they wouldn't be able to even participate, because they maybe they can't get in the car every day and drive there. Maybe they have to get off work, go home with their groceries and we're catching the bus, you know, all these things, you know, and really being able to do things remotely, it creates an opportunity for people. It creates opportunity for people that need it. You know, I've seen family members of my own, you know, not have access to, you know, care that they need, and they lost their lives. So you know, this is actually, you know, not just important, but it's very important to me. I mean, it's very sad, you know, when you go into these communities and you see people literally not have access to the care that they need to stay alive, like that, you know, and that has to change. And I think just, I mean, you know, from the work that I'm doing and this work, this is important. You know, this will literally make it possible for people to participate. But again, we have to be strategic in how we deploy it. We can't, you know, we have to make sure up front that people are educated, that people have access to this stuff needed to run the technology. You know, I mean, we could go on forever about it, but you know, it's truly important. It really is. Next slide, please. Now, tech literacy. This is a fun one for me. Now, with tech literacy, we have to, as decision makers, it is our job to really understand how tech literate the people are that we're working with. We have to have empathy. We have to have enough empathy in the things that we're doing, that we're willing to sit down and really understand the people that are going to be on these trials. You know, not just, you know, try and hurry up and get them signed. Like, we have to really understand these people, understand where they lack, understand where they need help, because that's how we're going to get to a point of where we're actually solving the problems and applying the technology where it's needed. We have to, you know, I mean, you know, I've had family members call me and say, "Hey, Adam, you know, I can't use this remote. I don't know how to use the remote." You know, and it's just like, it doesn't even have to be a phone or an iPad or any of that. You know, people, we just have to take the time and get people to understand what we're using, because if they understand it, this could literally save lives. This could make people, you know, this could give people access, like I said, give people access to clinical trials that would save their lives. And I'll be honest with you, up until I was about, what I get, about 21, 22-ish, had no idea this industry existed. I'm just going to be completely honest with you. The whole clinical research, didn't know it existed. I thought medicine was made in the air. You know, so we have to understand that I'm not the only one that has no idea, not just the tech. You know, we have to understand, we have to get them to understand what's actually happening in the trial and with the technology. You know, because it truly is like, if you're scared to do something and you don't know anything about it, it's going to be very hard. It's going to be a very hard sell. You know, so that's why I said we have to take the time up front. And it's not something that we can't do. It's just a matter of just taking the time to explain how it works. Explain how people can navigate whatever technology you're using. Explain to them, you know, where you can help them. Things like that. That's going to go a long way, especially if we do it up front, because you don't want to get, like I said, you don't want to get into the trial and then find out, you know, the granny over there or whoever it is, you know, maybe it's an old guy or something. They don't know how to use the phone or the app, or it could be something small. And we also, as we develop the technology, you know, for a clinical trial, whatever you're deploying it for, we need to make sure that, this goes back to the tech literacy. We need to make sure that that it has the communities in mind that it's going to be used for. So we need to make sure that, like, you know, if the app is going to, you know, if predominantly African Americans or Native Americans or whoever are going to be using this app, we need to make sure, we need to get their opinion. Hey, does this layout work for you? Do you know what this, you know, are you able to, you know, does this make sense to you? We need to really make sure that, you know, people in general are involved, because like I said, that's going to naturally kind of build that trust with the device and increase the literacy at the same time. Next slide, please. All right, so this is very this is very important. So the use of remote monitoring must always be voluntary. To protect the voluntary nature of use and or participation, when considering using connected sensor technologies in care and or research, we must always try to make sure, essentially we must always try to make sure that whenever we're deploying this, you know, we cannot create a value proposition. We can't make it feel like we're, you know, saying, hey, if you use this technology, you can, you know, keep it. Or we can't make it. We can't try to convince them to join the clinical trial by using this technology, because that's going to create some ethical issues that we don't want to run into. So this technology needs to be used in such a way that we are only deploying it for the people that, like I said, that need it. And that goes back to the whole survey thing that I said before, strategically putting it in the hands of people that you know, need to use it. So to protect the patients from being compelled to use the technology, where it would not, you know, limit the quality of care received, a comparable option, you know, for patients that do not, you know, require use of this connected sensor technology should be available. So if you don't need it, you know, we don't need to give it to you. You know, if you can make it to the site, maybe you don't need remote monitoring. Maybe you could just drive to the site. If you need some other technology at the site, though, maybe we can give it to you. So it's just a matter of filling out the situation, understanding what people need. To protect the voluntary nature of participation in public health initiatives, public health agencies should put forward a compelling education campaign for why individuals should choose to participate rather than mandate their use. So basically, we need to, this goes back to the whole justice piece. You know, we need to have a system in place that educates people, that makes sure that it's being distributed fairly, and it's not creating any advantages for those that, you know, even those that are not using it. You want to make sure that everything's fair. But those that need the resources truly need it. Those that need remote monitoring are going to need it. This is going to be crucial. I wish that, you know, some time ago when I was working on clinical trials, I wish this was available, but it wasn't. You know, like I wish that this was here. You know, when I first started, but it wasn't. And you know, having access to this kind of technology it's going to change clinical trials. To be honest with you, I mean, you wouldn't believe how many people get left out of clinical trials because it's just not feasible for them. You know, I've seen situations where, you know, 300 patients were white and 7 were black. Like, that's insane. I mean, from a pure science standpoint, you know, that is like, that just shouldn't happen, you know, and it has been happening for a long time. So it's not like, you know, we're just now noticing this. Like, this has been happening for a long time, and I truly believe that remote monitoring is a tool that we can use to bridge that gap and give people, you know, like I said before, give people access to these trials that truly need it. Next slide, please. And clinicians and investigators should ensure that access to technology does not compel use. So this basically just reiterating what I said before, just, you know, making sure that it's not, you know, compelling people to, you know, participate, or, you know, you don't want to convince people to participate in trials, because that's going to create ethical issues that you do not want to run into. But, you know, I think that, you know, moving forward, as we, you know, begin to progress through these clinical trials, and we start to, you know, get to a point where we're using these technologies a lot, I think we have to make sure that the researchers are trained. We have to make sure that the researchers understand how to identify those disparities as we're deploying these technologies, because you don't know where, the thing is, you don't know exactly where the disparities are going to come from. So it can become a kind of a puzzle in terms of ethics, you know, as you're going. So you have to be strategic, and you have to present the technology. You have to present the technology not as a selling point, but as a, hey, by the way, we can do this for you if you can't, if you have issues with this, so it needs to be presented in that way versus we have remote, technology that can, then people are going to want to join, and that's going to create some issues in terms of, recruitment and all that stuff, because like I say, you want to be ethical. Next slide, please. Now, okay, disparities in access to technology, broadband, and tech literacy can cause disparities in access and outcomes. So this is essentially what I was saying a few slides ago. Essentially what we're saying here is that if we don't make sure that we take the time to understand these disparities, people are going to be left out unintentionally. We have to understand that, hey, if, like I said before, if I don't have a smartphone and everybody on this trial is using, a technology that requires a smartphone, I'm going to be left out. If it requires me to have broadband and I don't have, any type of internet at home, then I'm going to be left out. If I don't understand how to use the device, I'm going to be left out. And all these things can skew your outcomes. If you don't catch it up front, it can create some issues. So really, like I said, I can't say this enough. Spending the time on assessing, up front, how these people should receive this technology is going to go a long way. Because, like I said, it is very important to deploy this. I really genuinely wish that we had this before, but this is very important. And I think if we educate people on how to use this, I think people are going to love it, especially people that really need these devices, and making sure that they can obtain those devices as well. Maybe, getting a class 2 and, being able to get it paid for through the insurance, things like that. I think it's going to be critical. And we can truly build trust. We can. It's just about doing it the right way. Next slide, please. So be intentional about instilling fairness and equity. Decision makers should evaluate whether and how connected sensor technologies they deploy may be received and check assumptions about the use of technology that may not be shared across a study or patient population. So we have to, essentially what this is saying here is that, like I said before, we have to be fair. We have to be mindful in how we deploy these technologies, and we have to make sure that, as we deploy it, that no one's getting an unfair advantage. I can't say this enough. The technology that we're using here is amazing. It really is. This is crucial. This is needed. I interact with underserved communities every day. I'm from an underserved community. I know what it's like to not have these types of resources. I know what it's like to not have the information, all of it, So it's not like you're just bringing people up to speed on, just the tech. All of it. We need to spend time with all of it. But, we have to be fair about it. We have to be fair. We have to be mindful as we move forward. And I think this is going to truly, save lives if we deploy these correctly on clinical trials. It's going to give people access they need it. We're going to see more, diversity in clinical trials because people, they'll be educated properly on the technology. They'll want to use it. They'll engage it, and they will, be able to, gain that access. And I think this is my last slide, I believe. One thing that I want to say before we wrap this up, I like to leave people with a message. As we move forward and use this type of stuff, to really bridge the gap between giving people access and making it fair and all these things. We should always try to be diverse. We should always try to make sure that people are included. Think of life as like a race. You don't want to, there are some people are in wheelchairs, some people are fine. We want to make sure that everybody has a fair chance, and have the ability to, to really move forward and have access to the resources that they need. And it's going to take a team effort. But that's all I have. And, thank you so much. I appreciate it.
Fantastic. Thank you, Adam. John, you had a couple of remarks, I think, as well, and then we've got some questions pouring in, and I'll start fielding them directly to all of you. This is terrific. John, what can you add?
Actually, why don't we go to the Q&A? I want to get to some of the questions from the group, and if we have time, I'll work in my anecdote at the end. But I want to hear from the audience.
Ooh.
Fantastic. David, I'm going to try and unmute you in case you'd like to pose your question directly. You should be able to unmute yourself at your end and then go ahead and pose your question.
Thanks, Jennifer. Can you hear me?
We've got you.
Anyway, I was listening to this, and it sounds like it's a menu of decisions and choices that we all have to remember. And I don't know if you're familiar with the book Checklist Manifesto by Dr. Atul Gawande.
Yes.
He introduces the idea that, if you're going to take off in your airplane, you want to check that all of the buttons and switches are set correctly before you take off. And he, for those who may not have heard about this, he then advocates and talks about how he implemented this in surgery, that before you get started, you go through your checklist to make sure you've got everything. And I'm wondering if you've seen, or whether it's maybe an idea to consider, to try to compile this into what would amount to a handy dandy guide for researchers to say, in order to address this menu of concerns, what would be a good way to have a checklist that you could go through? Have you seen anything like that, or does that sound like something that would be useful?
I'm guessing this question is for me.
Yeah.
So in terms of the checklist, I have not seen a particular checklist out there, not to my knowledge. But I think you have to start you have to start at an individual level, really, to be honest with you. And you have to understand that you have to really kind of work your way through it and then look at all the layers. But I think I agree with you. Creating a checklist is going to be, it's going to be critical. I have not seen one personally, but I do think it's valuable. From my experience, trying to navigate this, it's been, trying to identify all the angles, because there are just so many, to be honest with you, that you need to worry about when you're working on a clinical trial. But I completely agree.
All right. Well, Jennifer, maybe a chapter in the playbook could have at least a skeleton checklist with the idea that, of course, it would need to be tailored for individual circumstances.
Yeah, I'm just going to jump in that.
Yeah.
I'm really glad that you suggested that. The ethical considerations section of the playbook can be seen as kind of a pre-checklist. And so the idea of that is that it helps teams understand all the nuances and the issues that go into ethical consideration. But when you go through the playbook, throughout the playbook, but also in that section, we have spotlight slides, and we also have tips slides. And so if one wanted to, perhaps someone on your team or anybody who's watching this could go through the playbook, and if somebody wanted to consolidate it into a more concentrated checklist, then I think we have a really great starting point. And there's always, anyone can give feedback to the playbook on the playbook site. There's an option to give feedback. And also just through Dyne Society, if somebody does come up with a checklist after looking at our playbook or independently, it would be really great to see what they make of it.
I should have let you answer that one, man.
And one of the things, and we were chatting about this a little bit in advance, David, so it's a great question, is sort of as the group was working on the different elements that are sort of teased out in that section, it's really impressive that we're not just looking at sort of the more visible areas where there could be sort of bias built in, for example, you know, let's say in things like, as Adam illustrated really nicely, challenges around tech literacy or even access and trust in the tech, but also things like the more hidden pieces. For example, algorithmic bias is sort of documented in there as that checklist. And you know, David, I know that's something you're familiar with. And so it's that sort of that comprehensive checklist that includes both the visible and the invisible risks of bias when we start to think about using these technologies.
Sounds good.
Fantastic. Jim, I'm going to see if I can find you, Jim Dosha, and unmute you. And if not, I will pose the question on your behalf. But if you are somewhere where you can talk, Jim, feel free to go ahead. You'll need to unmute yourself at your end.
Okay, thank you.
We've got you.
Yeah, so that was a great list of recommendations about things that you should do to bring equity to the trial process and the use of digital health. And I was wondering whether we were yet at the point where we were meeting that standard for regular clinical trials, because I think there's still, in non-digital health clinical trials, it still seems like there's a big gap between where we should be on equity and where we are. So do you have any comments about that?
I'm sorry, you're asking about to make sure I understand you correctly, you're asking about the current state of where we stand in terms of diversity in clinical trials? Yeah,
just on non-digital health trials, it seems like there's still a big gap.
Yes,
between where we should be and where we are. And would that be your view?
Yeah, so I in terms of, if I'm answering correctly, I think right now, like what you're seeing, using COVID as an example, what you're seeing right now happens with a lot of trials. A lot of trials that, do not have this digital component. I mean, they're definitely, just from my experience, it's been challenging to recruit in underserved communities. It just naturally is. And a lot of it occurs because, from a project standpoint, you're always worried about timelines. You want to make sure that speed is important, to the sponsors in getting their drug out. But that's also another reason why people are being left out, because not everybody's you don't have time to educate people if you're trying to speed to get the drug. You don't have time to educate the patients that need to be in the trial if you're trying to speed to get the drug to market. So we have to be mindful and find that balance where it's like, let's make sure we're able to educate these individuals, get them the tech they need so that they can participate, or get them free rides or whatever it is to get to the trial and participate, and bring them into the trial. But right now, no, I mean, we have not. I don't think we've made a ton of progress. I mean, in terms. I
mean, just in regular clinical trials. I mean, for sometimes it's an all male cohort or mostly male cohort. Forget underserved communities. You're not serving 50% of the population. So it just seems like this is not. I mean, this is great recommendations for digital health, but it seems like the whole system. I know it's been getting better, but it still seems it's kind of broken.
No, it is. Absolutely. And it starts, I'm going to tell you exactly where it starts. This is actually why I created my company, because the feasibility process is important. That's where we design the strategies. That's where we, decide where we need to go from a country standpoint, where we need to go from a site standpoint. So we're actually, one of the things that I noticed is that 82% of the research sites that we go to in clinical trials have run, so 82% of the sites that have run clinical trials have run 10 trials or less. So we have locations like MD Anderson, of course, oncology and all that stuff. We have places like MD Anderson that have run over 5,000 trials. And then you have most of the other sites that have run like 10 or less. So by doing that, we're also limiting access. We're not going to, maybe this, doctor's office around the corner has a good, diverse population, but we're not going to that because we're going to the hospital that's 40 minutes away from the people that actually need it. So we have to think, there are a ton of factors at play. But it honestly all starts with the feasibility process. We have to really spend more time in that spot and deploy these types of technologies at the same time to really start to make some change in terms of diversity.
Thank you.
John, you've done some work in this area as well, I think.
So just to go back to the digital part, so everything Adam has said is exactly right, and you should follow him and subscribe to his newsletter because he's saying the truth. Digital has an extra weird thing to know about, which is that you may get success early in your sort of what looks like engagement in terms of your downloads, but when you look at who actually re-engages over time, even when you can recruit a diverse cohort, you frequently see that diversity fall out over a 30, 60, 90-day time period as people engage in what you're doing. And so you have to build something from the very beginning. If you're gonna design for trust and justice inclusion, it has to be in every part of what you do. It can't be just an extra thing that you do, because otherwise you start making it a trade-off with your other metrics, as opposed to centering that as what you do. If you have a consent process that takes too long, your engineers and your scientists will say, you're hurting enrollment, as opposed to saying, no, a boundary condition is that everyone understands the consent process. And so, in the studies that have actually centered those things as design requirements, right, not nice to haves, but gotta haves, there is evidence that this concept of a standardized way of recruiting intentionally for enrollment that's diverse and oversampled of the underrepresented can work. We've seen this at the All of Us research program in the US. And also that you can roll those elements out through things like informed consent and make sure that those are as informing as possible across as many demographics as possible. It's doable because at the All of Us consent, you see 90% of the people can answer questions accurately about what they just got shown across all demographics. But if you make it an option, it will always lose against the speed of the research. It has to be a foundational boundary of the project, not something that is up for haggling when you're talking about cost, speed, and metrics.
Right. So you make an extremely good point. We have to get away. Speed is important, but if we're trying to solve this problem, we can't think about speed. That's literally, speed is the reason why we can't solve it, because we're so focused on trying to hurry up and get there that we're leaving the people behind that need it. So we have to get away from this whole notion that yes, we know speed is. I wish we could move fast and get everybody in the trial, but we're now seeing that doesn't work. So we have to go to something different so that everyone's included. It's literally that simple.
Fantastic. Jim, thanks for a great question. And Adam and John, thank you. I'm going to see, Claire, if I can unmute you. And while I find you on the list here, I'm just going to sort of underscore, Adam, some of the remarks that you had that are so good. I was sitting here taking notes while you were talking that I think gets to Jim's point around these aren't unique challenges to the use of technology. And I think what I really sort of heard from you, Adam, was your passion, which, we agree with, that technology can help ameliorate some of these challenges. It also brings new risks. And Dena, you talk about that in a really sort of lovely way. So how can we use these technologies, not as a silver bullet, but in a thoughtful way to really try and sort of solve some of these problems, recognizing that technology isn't always the answer. So Jim, great question. And Adam, I was going back to my notes from your talk. Claire, we've got time for one last question from you. You should be able to unmute yourself and then talk to the gang.
Great. Thanks so much, Jen. Hopefully you guys can hear me.
We've got you.
Okay, great. Yeah, I mean, this is more a comment, but obviously for discussion. I mean, I think increasingly technology firms working in this space do user experience research around their studies. And I think when we do this user experience research, we're often looking for kind of an average patient to do that user experience research for. And one of the things that this conversation really strikes in me is that maybe we should be doing that user experience research in the hardest and the most challenging to reach population so that we can build our training modules, our patient education materials, and our overall model for the trial optimized for that patient that's having the hardest time getting connected. And then when we train either a physical site or a virtual site to be working with participants to get them up to speed on the technology, they're given the freedom to skip some steps if the person already has a smartphone and already knows how to use it. but that we assume that the person doesn't necessarily kind of have that know-how, and that we budget time for people to spend with participants, et cetera, accordingly, so that we ensure that it's not like, oh, I have this patient who's going to take double the amount of time, and so therefore I'm just going to go with the easier person who already has the smartphone, which I fear is sometimes what happens on the front lines. And I don't mean for that to be a criticism of anyone on the front line, but we really need to be thinking about planning for that up front, doing the user experience research with those people, and then, you know, whoever the site staff is, you know, giving them enough budget and giving them, you know, the bandwidth to really spend time with these participants.
Absolutely. You know, I think what you said is, especially with the whole user experience, the whole user testing, I think that's important. One reason, because, you know, like you said, if you're thinking about the average person, if you're only thinking about the average person, well, you're not dealing with the average person. You know, you're dealing with people that don't have access to, you know, things from, I mean, literacy, all that stuff. They don't have the resources to some of these things. So really preparing for that is going to solve a lot of your work, or a lot of your issues. I mean, that was a brilliant point. And also from a site standpoint, one of the things that I've dealt with from engaging with sites, you know, they want to be able to engage communities. They want to do that type of stuff, but the sponsors or whoever makes the budgets, it's not always factored in there. So you know, I think you make some really great points. I think we need to invest in these areas, and really make sure that that the people can get these tools. I mean, it's needed.
Fantastic. And John, I saw that you popped a comment in the chat as well, and I'm with Adam. This is, Claire, really important and thoughtful comments. We're a minute away from the top of the hour, so I want to be respectful of everyone's time. I know we're all hopping from one call to the next, and I want to be respectful of not just our phenomenal presenters, but also all of you who sort of tuned in today to be part of this really important discussion that mustn't happen just in isolation. As Dena said, there are elements throughout the playbook that address this, embedded in the playbook itself, in the ethics section. And also, I am incredibly proud to have really passionate and innovative thought leaders. Adam, as John said, we should all be subscribing to your to your blog that you mail out. It's absolutely terrific. You really sort of help bring all of us along in our thinking. And what I really like about that is that it reinforces it. This should always be front of mind. So John, Adam, Dena, thank you so much for leading this conversation today. Folks on the line, and Bernadette and Mary Beth in particular, I'm sorry we didn't get to your questions. Let's bring them over to the Dime Slack. We'll continue the conversation there. And just so folks know, the recording and slides will be up on playbook.dimesociety.org, along with the other classes in our masterclass series. Next week, we have colleagues really taking a deep dive into using the playbook for clinical research. So that will be a terrific session hosted by our colleagues from Myocardia and Genentech. But with that, John, Adam, and Dena, thank you so much. Really appreciate your time this afternoon. Thank you to everyone who joined us, and have a great day.
Thank you. Bye.
Bye-bye.